Reproductive pathology, placental disorders. All right, starting off, we have the placenta accreta. Placenta accreta lasts on a spectrum, okay? It acts on a spectrum. What does that mean? That means there's 3 different types of placentas, accretas, right? So you have placenta accreta, the actual one that they talk about, the main one that we care about. And that just means that our placenta, okay, is attached to our myometrium, all right? So essentially, our placenta is just stuck to the myometrium. Placenta increta means that our placenta is going to partially invade our myometrium. So it's like actually within the myometrium. And then placenta percreta has the ability to go past through completely invading the myometrium and then go even sometimes extending into adjacent organs like the bladder. Okay, the bladder is a question that they like to ask. Where can placenta percreta invade to, right? Now, the question is, how does this get caused, okay? Why does this occur? Why does placenta accreta occur? All right. The reason we have the placenta sticking to the myometrium is because of an increased risk of C-section. Okay. So if you had a prior C-section, that is your biggest risk for getting a placenta accreta. And the reason behind that is because during C-section, you're scraping off the placenta to take it out. All right. And in that process, you can scrape off this layer known as the decidual basalis. And the decidual basalis is essentially this thin layer of cells that protects the mother's myometrium, okay? It lies over the myometrium. Even though it's a very thin layer, it protects that myometrium. But during C-sections, you're able to scrape that layer off without knowing it, and that leads to a bare myometrium. So the next time you get pregnant, the placenta can essentially just stick right on to the myometrium without any protection of the decidual basalis. They love that. They love to ask you about that prior C-section being a risk factor and secondary to the fact that we've scraped off the decidual basalis. All right. So the question is, how is the patient going to present? Well, the patient's going to come in, all right, and it's time for delivery, but we can't deliver the patient. It's very, very hard to deliver the placenta. Okay. So we've delivered the fetus, but the placenta won't come out. Okay. So we have to go in, and as we're trying to deliver the placenta, they say the placenta was extracted in pieces. Okay. And that means that it was sticky. It was so hard to deliver the placenta because it was stuck to the myometrium. We had to extract it in pieces. And there was massive, severe postpartum hemorrhage. Okay? And the reason behind that is because your blood vessels are now through the myometrium. So as you're trying to take out and extract the placenta, you're ripping up all those blood vessels and you have severe postpartum hemorrhaging. Okay? Those are the 2 things that they will present as. Okay? If you ever see that, if you ever see the placenta was difficult to extract and they extracted it in pieces, difficult to deliver, but they extracted it in pieces and there was severe postpartum hemorrhaging, very important. That's like a trigger word. That means that it is placenta accreta spectrum. All right, moving on. Placenta previa. Placenta previa means that we have an attachment of the placenta over the internal cervical os. Okay, so normally the placenta is going to be more cranially, okay, in comparison to the mother. All right, so it's going to be closer to the head, right? But at times the placenta can actually be more caudally, and it can cover the cervical os, the cervix, the opening of the cervix. And when it does that, when it grows there, that leads to bleeding. Painless, though. Very key to understanding that this is painless vaginal bleeding within the 3rd trimester. Okay? So if you see a painless vaginal bleeding within the 3rd trimester, then you're dealing with the placenta previa. Okay? Easy enough, right? Next is vasa previa. Vasa previa means that the fetal vessels run over the cervical os. Okay, so they're over the cervical opening, but it's not protected by any of the placenta. So the placenta does not cover the cervical os. You only have these fetal vessels that are over the cervical os. Okay, and they're outside the protection of the placenta, known as the Wharton's jelly. Okay, so they're unprotected fetal vessels outside of Wharton's jelly. All right, and this leads to, once again, painless vaginal bleeding in the 3rd trimester. You're probably like, Nate, how can I differentiate it then? You just told me that placenta previa and vasa previa both have non-painful bleeding in the 3rd trimester, painless bleeding in the 3rd trimester. Well, the way that you differentiate vasa previa from placenta previa is that you have painless vaginal bleeding in the 3rd trimester, but also you have potential bradycardia of the infant. That's a very key differentiator, all right? They're never going to ask you to differentiate placenta previa from vasa previa unless they give you unless they tell you, like the placenta is over the cervical os or the vessels are over the cervical os outside of the Wharton's jelly. Okay, that's one way they could present it. Or the second way they could present it is if overall you have bradycardia of the fetus. Okay, very important. But they're both going to present with painless vaginal bleeding. The reason I'm saying this is because if you have painful vaginal bleeding in the third trimester, it's almost always placental abruption for the step 1 boards. Okay? If you ever see, once again, painful vaginal bleeding in the third trimester, it is almost always placental abruption. The question is, what does that mean? Placental abruption is premature separation of the placenta from the uterus before you have given birth to the child. So that means you are losing oxygen. The baby's losing oxygen because it's lost its blood supply from the mother, right? So you have no more oxygen coming to the baby. So, oh no, the baby's at risk of dying. And then not only that, you have the mother who's just hemorrhaging inside. She has internal hemorrhage. She's bleeding internally. So she is losing blood quickly. So she's at risk of dying. All right. And so she has abrupt, painful vaginal bleeding in the third trimester. It's severely painful. And this can lead to hypovolemic shock because she's losing so much volume, so much blood. Okay. And this can lead to like so many different types of things. But remember, it can cause hypovolemic shock. All right. If you see that painful vaginal bleeding in the third trimester, it's almost always placental abruption. All right. It's life-threatening to both the mother and the fetus. Moving on to uterine rupture. All right. So for uterine rupture, once again, it's not as high yield at all. This does present with painful vaginal bleeding in the third trimester. So you might be like, Nate, you lied to me. I thought you said anytime there's painful vaginal bleeding, it's automatically placental abruption in the third trimester. Well, yeah, it can be uterine rupture, but I told you for the case of the boards. The boards will ask you specifically about placental abruption. They really don't ask about uterine rupture. Uterine rupture is just full thickness disruption of the uterine wall. So you essentially just break the whole entire uterus. And it leads to painful vaginal bleeding once again. And then you will see easily palpable fetal parts, right? And you get loss of fetal station. What does that mean? It means a fetus is outside of the uterus because your uterus ruptured. So it's just floating around in your abdominal cavity. Okay. So that's why you're easily able to palpate the fetal parts because it's just like literally in your abdomen. And number 2, you get loss of fetal station because the fetus is just going to float around now. It's outside of the uterus. Okay. Once again, I don't remember honestly any questions on it, but it could be. Next is postpartum hemorrhage. All right. So for postpartum hemorrhage, right, this is a very broad topic, but this is one of the main causes of death in pregnancy. Okay. And they have 4 types of causes of postpartum hemorrhage. Number 1 is tone, uterine atony. You're going to see atony a lot, A-T-O-N-Y, and that just means that you have loss of tone. All right. So the uterus is a muscle, right? Especially with the myometrium. It's mainly muscle. And so what happens normally in pregnancy is that we'll have the myometrium contracting, and when it contracts on the blood vessels, leading to stoppage of bleeding. But if you have the loss of that tone and that muscle is unable to contract, it can't contract on those blood vessels. So you overall start to lose a lot of blood. All right. Very important. And that's the most common thing. The others are trauma, tissue, and thrombin. But honestly, I don't care about it because the tone is the most important one. So you can do a uterine massage or give them oxytocin. Why would oxytocin work? Well, the reason oxytocin would work is because that would cause contraction of that uterine muscle, the myometrium, leading to compression of those blood vessels and an overall decrease in postpartum hemorrhage. All right. Very important. All right. What we have to do to stop the bleeding is we're going to have to ligate the internal iliac or uterine arteries to stop the overall postpartum hemorrhaging. All right. Now, ectopic pregnancy is the last pathology I'm going to talk about. Ectopic pregnancy is very, very high yield. So what happens is that we have implantation of the fertilized egg, okay, of the embryo in the fallopian tube, okay? It mainly gets fertilized and implants in the fallopian tube for ectopic pregnancies. It doesn't make it all the way to the endometrium, all right? So it's most often in the ampulla of the fallopian tube. Very important. And the reason behind that is because you can have risk factors that lead to an increased cause of ectopic pregnancy. And that's going to be PID, which is just tubal pathologies, okay? So that means that we have like fibrous tubules. So when we have fibrous tubules, that means that fertilized egg can't really like get through because there's so many fibers like and adhesions that are blocking my way to the endometrium. So I'm just going to sit in the fallopian tube and just like stay there and start growing. All right. And usually the tubal pathologies associated with this is PID, pelvic inflammatory disease. Okay. And that's secondary to patients that have had gonorrhea or chlamydia in the past and did not get treated for it. Okay. So keep that in your back of mind, but that's going to be mainly for micro, but they love to ask about that. Chlamydia and gonorrhea. Okay, Neisseria, gonorrhea, and chlamydia. That causes PID, which causes scarring of the fallopian tube. So it's very hard for that fertilized egg to get through to the endometrium. So it just sits and it implants himself into the fallopian tube. All right. So how is the patient going to present? The patient's going to present with first trimester bleeding. All right. So if you see first trimester bleeding, start thinking about this, and they have lower abdominal pain. All right. Now, clinically, I'm going to look and they're going to have lower than expected rises in HCG based on dates. So you could say, hey, I haven't had my period in like 4 weeks, right? I haven't bled in 4 weeks. And then they go and they look at their HCG levels, and their HCG should normally be like 10,000, let's say, but it's only at 2,000. So that's a really high indication of ectopic pregnancy. A lower than expected rise in HCG is what they call it. All right. Then you're going to do an ultrasound and you're going to see, there's something within the fallopian tube that's growing. Now, this is a big, big issue because if you continue to grow, which you will, right? It's a growing human being. It's going to cause a rupture of the fallopian tube, and then you start to bleed out internally, right? So the patient can present with hypovolemic shock if it ruptures, all right? And you're going to get intra-abdominal bleeding with rebound and guarding, right? So rebound and guarding is just like pain upon, essentially rebound is like when I push down on an area and I let go, you get pain, okay? That's rebound. And then guarding is then when you push down on something, like when you're doing like a physical exam, someone is like flexing hard rather than just like relaxing and allowing for the physical exam to occur. Okay, so keep that in mind. All right, now what's the treatment? The treatment is methotrexate, MTX. Okay, it inhibits DNA synthesis to destroy the proliferating cells, the proliferating fetal cells. Okay, because we cannot carry this pregnancy to term because there's no way, one, that the baby is able to grow because it's not at the endometrium where the nutrients are at. And if it's going to grow like only a little bit, but the little that it grows leads to just the rupture of the fallopian tube, and it could cause death in the mother too. So you have to terminate this pregnancy. It's the only treatment. And you terminate it by giving the patient methotrexate. It inhibits DNA synthesis, and that destroys the proliferating cells of the fetal cells within the fallopian tube. All right. Now, you might know, not to get political or anything, but it's interesting because it is currently in the news 24/7. Methotrexate was banned in some courts in some states. And so they're talking about the legality of it within the Supreme Court. And they make decisions on that. So this is just one thing that you can kind of relate to real life. All right. So everything that we learn isn't just something that happens in a vacuum. All of this is very important, and you can see why it matters. Okay. So that's it. That is our placental abnormalities and pathologies and disorders, as well as uterine rupture with postpartum hemorrhage and mainly ectopic pregnancy. They love to talk about ectopic pregnancy. Next, we'll be talking about hydatid-form moles and moving forward with other pathologies.